Hello, welcome to this World Stroke Organization Global Policy webinar. This is the last in the series this year, harnessing civil society organizations to drive improvements in stroke treatment. And we've got three excellent speakers who we will introduce. I'm Gary Ford. I'm an academic stroke physician in Oxford and on the WSO Global Policy Committee. And my co-chair is Valerie Fagan. I'll just let Valerie introduce himself.
Thank you, Gary. I'm Valerie Fagan, Professor of Neurology and Epidemiology, and I'm co-chairing this session with Gary.
So we'll have the three talks. The webinar is being recorded and will be accessible to participants after the meeting. We have a Q&A box, so please do post your questions in that, and we will have a discussion session at the end after we've had all three talks, and the webinar will last no longer than 90 minutes in all. We did have four speakers, but one, Joe Lambert, who's going to speak with Julia, is unfortunately unable to join us today, so we'll have the three talks and then about 20 or 30 minutes of discussion. So I'm going to hand over to our first speaker, Michelle Nelson from the University of Toronto. Over to you, Michelle.
Thank you so much. Okay, let me get my slides. How's that? Can everybody see my slides? Excellent. So thank you for the invitation to speak with you today. My name is Michelle Nelson. I am a scientist within Sinai Health System, which is an integrated care system in Toronto, Canada. I'm an associate professor in health policy management and evaluation at the University of Toronto. I'm also the vice president of the stroke support organizations for the World Stroke Organization. So this topic is near and dear to my heart. But I thought I would start back a few years. So a few years ago, a patient, and I'll call him Bob for the purposes of today, he looked at me and he said, with a very confused look on his face, "You all keep talking about community reintegration or transition back to my community, but I never left my community. I was just in the hospital for a while." And that snapped me to attention. And I thought, when and why have I disconnected hospital from broader society? When did I stop thinking that healthcare institutions were part of broader society? And the more I thought about it, the more I wondered, well, how would that change my approach to clinical practice if I saw the world the way Bob did? So that shift in perspective has really served as the backbone for my program of research for the past decade, really examining mechanisms, approaches, and value of partnership between healthcare and civil society. So I'm going to work under the assumption that if you're joining the session today or you're watching the recording, that you are already either seeing the value of civil society or you have a keen interest. So rather than try to convince you of the value of third sector, I'm hoping that we can spend our time talking about some of the things I've learned about partnerships between civil society and healthcare, what some of the things I'm grappling with, and some of the things that I think we all collectively have an opportunity to think through and work through. So I'm sure most of you are familiar with this saying, the best time to plant a tree was 20 years ago. The second best time is now. And as I reflected on the evolution or the development of stroke care and pathways, it struck me that this is a conversation that perhaps we could have been having all along. But retrospective, to hindsight's 2020. So thinking about the second best time is now. And there are some pressing health system issues that I think we need to be aware of as we have this conversation. Most of us are working in environments that have increasingly complex patient populations. We've got funding, resource allocation, and resource constraints. We've got this desire and a need to reduce cost while improving care quality and patient experience. And so that's driving all of us to think about innovative solutions to improving quality and reducing cost. One such way, and we're seeing this now in the literature, is the desire to partner with community-based organizations. So the Health Systems Learning Group, which is a group of 43 health system leaders, they convened, and in the summary of their meeting, they said, and I'm going to read it: as hospitals and health systems struggle under the weight of undercompensated care, emergency use overuse, and readmissions, the greatest proportion of which are directly attributable to spiraling chronic disease, the case for transformative community partnerships becomes increasingly clear. Then there's this really fascinating and fantastic quote from Dr. Waller, who's the former CEO of Mayo Clinic. And he very clearly said in an interview, the United States has three options. It can help less, it can spend more on healthcare, which hardly seems possible. I think most of us can relate. It can help less, which is unconscionable, or it can redesign healthcare by turning to the power of community to redefine healthcare and pursue true health. So, I'm sure this resonates with you, and in the Canadian context where I'm calling from, we have had a lot of conversations about high cost, high user populations, and stroke is clearly identified as one of those. And we are constantly looking for strategies and techniques to reduce the pull on healthcare resources while promoting population health. So when I saw the quote by Dr. Waller, or I heard him speak, I thought, well, that makes a lot of sense, and that's a really nice way to frame this. Now, the third reason that this makes sense for us to be talking about is the simple fact that the stroke support organizations globally are already engaged in this work. In 2019 and 2020, colleagues with the WSO, through the WSO, we undertook a survey of 92 SSOs across 58 countries. And we did this to understand the work that the SSOs were doing to promote health and well-being for people with stroke. And as you can see on the slide, respondent SSOs noted that they are already immersed in the world of stroke prevention, stroke awareness, providing treatment and rehabilitation support, and then long-term recovery, particularly around education and peer support. So what it suggests is we've got the perfect time for us to capitalize on the work that's already happening, the desire to change, and the health system pressures that will create a burning platform for us to move the work. I thought you would also be interested to know that when we asked the SSOs what were some possible solutions to the challenges they faced, 88% of them identified partnerships as an opportunity to reduce, to overcome some of the challenges. And it wasn't partnerships sort of unilaterally, it was partnerships in the broadest sense between SSOs, with government, with clinicians, with academics. And so the conversation we're having today and some of the programs of work that I and colleagues are leading really is driving toward trying to improve or support that ambition. You can see I'm giving you some of the others, and of course, collaboration, data, improved skill. It really speaks to the need to support SSOs with the expertise that we hold in other fields. So speaking of expertise, one of the things that I'm grappling with is this idea about, are we actually now in stroke systems of care victims of our own success? This idea that with our scientific advancement, with clinical techniques improving, with the professionalization of care, all of which are very important for producing good outcomes post-stroke, we have also, though, created a situation where we've prioritized the expert. And with our increasing reliance and value placed on expertise, I think sometimes we lose sight of the fact that much of what produces health in the general population are actually outside healthcare services. So I've given you a graphic, but I'd also like to point you to a study led by a colleague in Alberta, Canada, by the name of Richard Luanchuk. And they looked at what proportion of health needs were actually met by health services in their province. And he noted that 10% of the health supports in their province were provided by formal health services. The rest were either through self-management, friends and family, or voluntary organizations. And so voluntary organizations is really what we're talking about today. So one of the things I really grapple with is, with the rise of technocracy, we see a corresponding devaluing of the types of knowledge and work that aren't built on expertise, a scientific approach, and high quality evidence, which for many people on the call today, I suspect resonates with the kind of work that often happens in community organizations by peers, by lay staff. And so as we have moved that capability out of community, high quality care, now we have to actually build capability and capacity in community before we can reasonably think that we're going to partner and work through some of those sort of thorny issues that we'll identify throughout the course of the discussion, I'm sure. For many of you, this will be this will be old knowledge, but I just wanted to remind people that when we think about civil society, there's the informal and then there's the formal civil society. So civic engagement is the work that we do in our local networks, with our friends and family, in our neighborhoods. And the third sector are often more formalized. They often serve as the voice of civil society, but they're not necessarily the same in terms of philosophy, mandate, etc. So, social capital, the idea of civic engagement, on a weekly basis, I do the grocery shopping for some of my elderly neighbors. That's me engaged in civic engagement. My role as a volunteer, as on Meals on Wheels or other organizations, is formal volunteerism within the third sector. And I make this point because understanding our relationship to the third sector civil society allows us to identify and determine what is the scope and role of civil society in our region. What are the best strategies? Is a formal collaboration agreement appropriate with the third sector? Are we talking about supporting and honoring and leveraging the work that civil society does in their neighborhoods? So I think we want to make sure that we tease this apart, particularly when we start talking about collaboration. And of course, I think we need to think about when we talk about civil society, there is this rich community life that many of our patients' families, ourselves, are embraced and engaged in. And so thinking about this group and all of the places that they're promoting health that we may never be able to reach. So that associational life, clubs, memberships, community events is so important. And we know the impact that that has on people's lives. It really draws to mind the work of Sir Marmot et al. And, the idea of why, the question of why do we keep discharging people to the conditions that made them sick in the first place? So this conversation today about health promotion and interventions and then long-term secondary prevention is so timely given what we know about where people promote health and well-being. We could spend the whole session talking about how community may be a solution or maybe a place where there are some innovative solutions to the challenges health systems are currently facing. But I thought I would draw just your attention to two things. So, we have a lot of discussion about transition challenges and how we determine where people go post-hospital or whether or not they have a safe, I'm going to put that in quotes, a safe place to go post-hospital. But we also know that we have a challenge around culturally relevant and tailored interventions, and we have huge disparities in our ethnically marginalized or diverse populations. And so I wanted to draw you to the thinking of what is a community solution to a health system challenge. And there are some really great examples. In the US, there's a model called the Memphis model, where the Methodist Bonheur healthcare system partnered with 600 Methodist parishes. And they formed collaborative agreements between a hospital-employed navigator and a volunteer in each of the parishes. And what that allowed them to do was connect an individual, the 20,000 rostered African Americans who were members of parishes, to individuals in their local community to support them in the transition home. So that was a solution in a community associational life, third sector space that allowed for partnership. It allowed for culturally relevant, tailored interventions, and it actually addressed a transition issue that is experienced by both the healthcare system and the person impacted by stroke and other chronic diseases. So I encourage us to think about those kinds of creative solution identification. We just recently completed a piece of work looking at models of transitional support by the third sector. A colleague that may or may not be on the call, Alana Armes, led that work on behalf of our team. And there are substantial models, programs, and services that are built to support transitions from hospital to home. And that's just one domain. We'll not talk about funding, we'll not talk about resource allocations, but at the end of the day, really there are opportunities to embed community solutions that actually have mutual benefit to the healthcare systems. And then in the overarching objective, we talk a lot about collaboration, and the session today, we talk about collaboration. And this is really where I spend most of my time. So thinking about solutions and innovations and partnerships with community spaces. So in 2020, the International Foundation of Integrated Care, for which I'm a senior associate, issued a call stating, let's be bold. Let's strive to build alliances between communities, businesses, local government, and health and healthcare services. This is the right time to build bridges over the traditional fault lines between professions and sectors. Let's shift power toward community-led health and place-based approaches to integrated care. And as many of us know, having worked in partnerships and collaboration even within a health system space, collaboration is not as easy as saying if there's a will, there's a way. So in my research, looking at the importance of preconditions, what was the historical relationship between the organizations? How much partnership had they had? How much trust is there between the organizations? Do they have a common goal? Do they have the similar philosophical foundation? It's very hard for organizations that work from a medical model, a charitable model, and a social model of disability or illness or health to find common ground unless they unpack that. We recently conducted a workshop looking at integration or partnerships between the third sector and health systems. And there were some very interesting insights that came out. Third sector leaders said, some of us are actually okay to do our work on our own time, on our own pace, under our own steam, and we don't necessarily need an outside force acting upon us. When we unpacked that, though, there was a history of tokenism being engaged for the purposes of saying that they had integrated with community. Others were fearful that there was task shifting. So one of the things I encourage is for organizations interested in collaboration with the third sector to start applying a framework. And the Tamarack Institute has a really lovely visual that we often work from, and showing the movement from our traditional specialized siloed ways of working to the idea of a collective impact approach. And so the collective impact approach really identifies having a common agenda. Do we actually have a backbone function? How do we organize ourselves? How do we organize our work? How do we engage in continuous communication so that we're all aware of what's happening? Harken back to the need for real-time data around prevalence, incidence, and prevalence in communities. Third sector organizations, SSOs, noted that need. And then you start to get into, okay, how do we actually do things together to benefit our population? What are those? Are they mutually reinforcing? And how do we know they have an impact? And so this type of framework is really helpful for organizations to work through a collaborative agreement for broader population health. So I'm going to just sum up by saying, while we're having these really fantastic conversations, and there's a lot of literature that we can pull on, the role and contributions of third sector in improving health experience and outcomes is really still unaccounted for or underaccounted for, and certainly under-recognized. And so if you familiar with the King's Fund, the American Hospital Association, the Burl Institute. They have all come out with advocacy statements pushing for more purposeful engagement of the third sector in the design and delivery of care. So the conversations like we're having today are so central to this engagement, and I'm appreciative of the opportunity to speak with you, and I'm very much looking forward to the Q&A at the end of the session. So with that, you can find me at mlanelson@sinaihealth.ca, and I look forward to your conversation at the end. I'm going to stop sharing my screen and pass to Lisa.
Thanks so much, Michelle. I am going to share my screen. Okay. So I'm going to talk a bit about advocating for initiatives to prevent, treat and beat stroke at a national level. And I'm going to do it very much from an Australian perspective. My name is Dr. Lisa Murphy, as Michelle said, and I'm the CEO of the Stroke Foundation in Australia. I've been CEO since about April, but I've been with the organisation for over 3 years now, so I know the Australian scene very well. You can hear from my accent that I originate from England, from London, grew up, born and bred in South London. So advocacy really is a journey, and there are so many elements to a successful advocacy campaign that I'm going to share some of them with you today, but obviously not all of them. And I'm going to do this by highlighting some of the successes we've had at Stroke Foundation Australia, and also some of the initiatives that we're working on currently. And a lot of these are in partnership. As Michelle says, you absolutely have to collaborate. So we do collaboration really well in Australia. So I'm going to demonstrate that as we go along. But before I begin, I would like to acknowledge the traditional owners of the land that I'm joining you from today, and they're the Wurundjeri people of the Kulin Nation. And I'd like to pay my respects to their elders, past, present, and emerging. Some of you might have heard in the news that at the moment we are due to have a referendum for the voice for Indigenous Australians in our constitution. So it's a very, very on-point topic. You'll see this beautiful artwork that we had designed for our Reconciliation Action Plan, and it really depicts the story of stroke. There's blood vessels, there's a hemorrhagic stroke, there's ischemic stroke, and then there's a strong element of community that comes right through that piece of art. Back to advocacy. So today I'm going to share with you a bit of the few peculiarities of advocacy in the Australian context. And then I'm going to demonstrate really the power of data in advocacy through the National Stroke Audit, and also show you how an initiative can grow from just a small pilot project to a national and then even international resource through the Living Stroke Guidelines. The Telestroke programme is a perfect example of how long advocacy can take, but that persistence really, really does pay off. And I'm also going to show you how important it is to get government involved right from the get-go through the Stroke Unit Certification Programme, and how important collaboration is in getting things done. And then finally, across all of these is the power of the lived experience experts in advocacy. So first of all, a bit about Australia. Australia is a huge country. You can see Australia takes up almost the whole of the United States, Canada, and Europe. It's absolutely massive. And it's divided into states and territories. And funding for healthcare is done at a state and territory level. It's not done at a national level. The other thing about it is most of the population is clustered on the eastern seaboard. And all of these elements together lead to real inequities in healthcare between states and territories, between rural, remote and metropolitan areas in Australia. And then top of that, we have the huge disparity in health between our First Nations people, our Indigenous people, and our non-Indigenous Australians. And this makes advocacy so much more challenging. And next, the power of data in advocacy. And I'm going to illustrate this through the Stroke Foundation's National Stroke Audit. The National Stroke Audit is an audit that we do on both acute stroke hospitals and rehabilitation hospitals, and we alternate each year between the two. We've been doing it since 2007, and the Stroke Foundation conduct the audit, but we get help with data analysis from the Monash University in Victoria. It's really by collecting this data, developing dashboards, monitoring hospital performance, that we really know how hospitals are performing. And we use this data to work with hospitals on improvements and advocated for improved care, such as the need for stroke units where they're needed. We recently did a review of the last 20 years of the acute audit, and we have actually shown that by measuring and doing quality improvement activities, that there has been an overall improvement in patient care. A good example of how we use the audit data in advocacy is the use of telehealth for acute assessment and the treatment of stroke. You can imagine that Australia is such a big country that telehealth is so very important. Excuse me, I'm just going back. So this table here shows the indicators for thrombolysis. And you can see that the rates of thrombolysis in a timely manner are better for those sites that have telestroke compared to those that don't. Later on, I'm going to talk a bit about telestroke, but we really use this data to advocate for telestroke in states where they didn't have it. Using living guidelines as an example, I'm going to illustrate how continued advocacy can change a small pilot project into a national and even international program. The first Australian clinical stroke guidelines were published in 2003 by Stroke Foundation. And at this time, they were your typical paper-based PDF static guidelines. And then in 2018, Stroke Foundation and Cochrane Australia, which are the founding members of the Australian Living Evidence Consortium, were awarded a 3-year government grant to test the model of living guidelines for stroke. And these were the first Australian living clinical guidelines and the first living stroke guidelines worldwide. We did an evaluation of living guidelines a couple of years ago now at the end of the 3-year program. And the results really showed that an estimated 321 Australian lives were saved or life-limiting disability avoided following severe stroke. And this was simply due to practice change from following these updated live guidelines. Since then, the Australian Living Evidence Consortium has actually become a collaboration, and it's really grown with over 12 partnership organisations led by Cochrane Australia. And we've recently got endometriosis into the collaboration, and they've recently got funding from the Australian government to develop the living guidelines. So that's a great win. When COVID-19 hit, the National COVID-19 Evidence Task Force was established, and this included 32 peak health organisations, and the task force became a member of ALEC. This task force rapidly turned the thousands of COVID-19 research papers into guidelines in just 20 days, which is a huge step change. And really the groundwork for this advocacy for these guidelines paved the way for this rapid translation of research into practice-changing, life-saving clinical guidelines. And it stopped the COVID-19 fake news in its tracks. Getting national coverage for telestroke in Australia was a great example of how persistence in advocacy really pays off, and that it really is a long game. Our journey started back in 2010 with a pilot program conducted between 2010 and 2013 in Bendigo in regional Victoria, which was then rolled out to an additional 15 hospitals between 2013 and 2017. South Australia was next on board in 2018, and then soon after New South Wales in 2019. And then we were on a bit of a roll. We got Tasmania in 2020, and then WA in 2021. And Northern Territory, which is supported by South Australia, came on board in 2022, but we were still advocating hard for that final state, Queensland. And then finally, in 2023, they came on board. That was 13 years after our first pilot in Victoria. Definitely a long haul, but well worth it. So now we've got the whole of Australia covered by telestroke. The next few examples I'm going to focus on is the initiatives we're currently developing. And the first is the stroke unit certification program and the importance of early government engagement. As you know, being treated in a stroke unit leads to better outcomes. So based on international learning, stroke unit certification is championed as a priority project for the Australian Stroke Coalition. And that's a group of all interested parties in stroke in Australia. A key step was to incorporate this as a recommendation in the National Strategic Action Plan for Heart Disease and Stroke, which is an Australian government policy document that was developed in collaboration with the Australian stroke and heart community. And you can see in that red box there that those are the two actions that we want to get stroke unit certification on board. So we started the project back in 2021 as a pilot, and each state and territory clinical lead was asked to nominate one site to trial. We had a mix of comprehensive stroke centres, primary stroke centres, and stroke-capable rural hospitals. To date, we've certified 11 hospitals, and you can see there's a great spread throughout Australia there. And here is the picture of the first hospitals we certified, and that's the Alfred Hospital in Melbourne in Victoria. And there's Jeff Cloud, who's the head of the unit there, looking very proud with his new plaque. So the pilot's been really successful, and we're planning to extend it to other sites with subsequent programme evaluation. And what we're really keen to do is get government support so we can get funding to carry it on. And then by 2030, what we're hoping to do is have all centres in Australia certified. You might be asking, you know, do the stroke units get automatically certified? And they don't. We've come across a couple where we've had to work with them to improve things, and we'll reassess them at a later date. The next advocacy initiative we're working at is the National Targets for Acute Stroke Care, and this is another collaborative effort. And this is really brand new. We launched it at the Stroke 2023 conference in Melbourne. Sorry, I've got a really sore throat. So the concept of time is brain was introduced over 2 decades, and you're all very familiar with it. Evidence supporting the correlation between faster stroke treatment and improved patient outcomes has exponentially grown, leading to system redesign supported by policy research aiming to increase to expedited reperfusion therapists underpinned by acute stroke care. But despite progress in treatment options, assessment and access to specialist care, Australia really does lag behind other developed countries in delivering acute stroke care and acute stroke unit access. We have variation in hospitals, we have care gaps, including system failures and treatment delays. And you can see here that we are lagging behind both the UK and the US. Access to stroke unit and medium door to needle times have not shifted between 2017 and 2022. So with a unified effort and voice, we've got an opportunity to change this, and this is through these proposed national targets. So this initiative is really, really collaborative. It brings clinical leads from each state and territory, representation from the Australian Stroke Coalition, including the Stroke Society and the Stroke Foundation, the Australian Stroke Alliance, the Acute Stroke Nurses Education Network, the Australian Stroke Academy, the Australian Stroke Clinical Registry, the Australian College of Emergency Medicine, importantly, people with lived experience, and also importantly, the Health Department policy advisors, and also the Angels Initiative. And by aligning on these targets, what we're hoping to do is really shift the dial on acute stroke care. The final thing we're collaborating on is the National Hypertension Task Force, so shifting a bit more into the prevention space. And this is another thing that's just kicked off. And what we're trying to do is improve hypertension control rates in Australia from 32% to 70% by 2030. And this is a collaboration of Hypertension Australia, Stroke Foundation, the Heart Foundation, and the Australian Cardiovascular Alliance. And really we'll be taking a lot of learnings from the Canadian perspective. With blood pressure accountable for 40% of strokes, it really can imagine the impact that this could have if we could achieve these targets. And finally, it's always better together. There's nothing like the voice of lived experience experts to bring the message home. And I would never go to a parliament or to an event without my gang of lived experience experts. And these are a few of my favorite lived experience experts in this photo. So in summary, I've shared a few lessons in advocacy and highlighted these with specific Stroke Foundation initiatives and collaboration initiatives where Stroke Foundation is a partner. I'll be more than happy to take questions at the end, and please do feel free to contact me on lmurphy@strokefoundation.org.au. I'll now hand over to Julia to present a perspective from New Zealand.
Thanks, Lisa. Just get my screen up and running. Hopefully that's looking like it should. Yes, okay. Well, tēnā koutou katoa. That's a formal greeting from Aotearoa here in New Zealand. My name is Julia Rout, and I'm the General Manager for Health Promotion and Advocacy at the Stroke Foundation. I've been with the Stroke Foundation for almost 10 years, and my background's in public health dietetics. So just before we start, a little bit about the Stroke Foundation. So the Stroke Foundation of New Zealand has been around for about 40 years and began with just 2 volunteer physiotherapists. Today, we've got about 70 staff, and our mission is pretty simple: to prevent stroke, improve outcomes, and save lives. Some facts about New Zealand. So for those of you that don't know where New Zealand is, shame on you, but no, we're not part of Australia. We're south of Australia and much smaller. So we have around 9,500 strokes in New Zealand each year, and that number is predicted to increase by 3,800 by the year 2028. A stroke happens in New Zealand approximately every 55 minutes, and it's costing our economy around $1.1 billion. And on top of the people that experience stroke, we've got also family members or whānau, so around 350,000 survivors and whānau living in New Zealand. But, you know, while there's an economic cost, we all know that the social cost of stroke is immeasurable. So our work at the Stroke Foundation can really be divided into 2 areas: life before stroke and life after stroke. In terms of our life before stroke services, we provide a range of outreach services in the community. This picture here is of some of my colleagues. We go out and offer free blood pressure checks around the country. We also do free pulse checks through our mobile outreach services. We have a role in leading our National Fast campaign, and we're also getting involved more in collective impact. So it was really cool to see that slide from you, Michelle, around the Tamarack Institute, and saw a presentation from a couple of people from there just a couple of weeks ago at a conference here in New Zealand. So what we're really trying to do is put the voice of family at the centre of everything that we do. Like in most countries, we have huge inequities in the incidence of stroke. So our Māori and Pacific populations are at significant increased risk of stroke, and that has not changed for quite some time. So we've realised that, you know, you keep doing the same things, you get the same results, and we really need to shake things up a lot more. And so we're putting everything that we do on the table with these communities that are at higher risk of stroke, and saying, you know, what's actually working, what isn't, where are the gaps, and then figuring out, you know, who do we need to collaborate with to create a system, and that's bigger than the health system, of course, that supports people to stay well, to prevent stroke, and then if they do have a stroke, to live well after stroke. We also, in my area of the Stroke Foundation, lead our work around advocacy, so quite a big focus on policy, particularly around reformulation to reduce the amount of salt in processed foods, but also improving the services for people that have experienced stroke, particularly around rehabilitation. We've got a big ask with government at the moment, although we're just about to go into an election in New Zealand, so things are sort of all very focused on that right now. And also just to add that in terms of our mobile outreach services, we test around, or last year we tested over 11,000 blood pressures, and about 2% of those people we found were in either hypertensive urgency or emergency, and about 30% needed further follow-up due to a higher reading. In terms of our life after stroke services, one of our main services that we provide is a community stroke advisor service. So that provides information, support, service navigation to help people connect with the support that they need after they've been discharged from hospital. We receive personal referrals for that service, and we also receive referrals from primary and secondary care. So in the last year, we had just over 5,000 referrals and had just under 3,000 people engage in that service. We also provide a return to work service, so working with people that have experienced stroke and their employers to get back into paid employment after stroke. We know how important that is for multiple reasons. And last year we supported just short of 300 people, and 220 of those people were still in paid employment after 12 months. We also are running a pilot at the moment, which is around delivering the Taking Charge After Stroke initiative. That's the only evidence-based person-centered self-rehabilitation intervention for people that have experienced stroke and have been discharged home. We're self-funding that pilot at the moment, and that initiative was actually developed in New Zealand and has been shown to be particularly powerful for Māori and Pacific stroke survivors. So we've got a big focus on that at the moment. But what I am going to mostly focus on today is a new initiative that we've designed with the construction industry. So, we know that in health and construction in particular, there's a big focus on health and safety, more so on the safety, less so on the health. And so we partnered with an amazing organisation called the Building Intelligence Group, who are a construction project management company, to co-design this initiative for the construction industry, which brings health and wellbeing experts onto construction sites. And we're working towards getting government buy-in across a number of our departments in New Zealand to have Health 15 as a prerequisite for tenders on construction sites. So firstly, why was Health 15 developed? Well, in New Zealand, and I think that's also in Australia, we've got a male dominated industry, and there's a real she'll be right attitude. People leave things to the last minute and they don't reach out until there's quite serious symptoms or signs that something's not quite right. And so this was really an opportunity for us to channel into a market that was at high risk of stroke. There's also the long work hours and the stress that comes with working in construction can make it hard to prioritize your health, and also the lifestyle factors that often come with working on construction sites, the pies and the cigarettes and vaping and all of those sorts of things. And plus, given the long working hours, it can be really hard to make doctor's appointments as well. So this was an opportunity to take the service to construction sites and support that early identification. And also, we spend a lot of our time in our workplaces. So it was a way that we could work longer term with sites to provide an environment that was supportive of health and wellbeing and keeping people well. So what is Health 15? It's more than a test and leave screening program. We already have, a lot of construction companies do occupational health screening. So, eyesight, hearing, lung function, somebody comes in every year, does those checks, and then they leave. our goal is to work with a construction site longer term and to plant some sustainable seeds that will support health and well-being much further into the future. It's a targeted approach. So our mobile outreach services go to events, cultural events. We also will go to supermarkets, and we'll get all sorts of different people through the vans that way. But by going to a workplace where we know there is a higher proportion of people at risk, it's an opportunity for us to get bigger bang for buck and make sure that our funding is going where it's actually needed. As I've mentioned, it supports early identification. We know that hypertension often doesn't, well, most often doesn't have any signs or symptoms, and the only way to know that someone has high blood pressure is to get a check. And in New Zealand, a GP visit could cost around $67 or more, and we've got a cost of living crisis. That's food for somebody to put on the table for their family, and so it's often difficult for people to prioritize that investment. It also breaks down barriers to access primary care. A lot of the people that we see on construction sites don't have GPs, or can't get into a GP as well, and so it takes a service to them. It removes the time and the cost barrier to getting those checks. So Health 15 works in four key steps, and actually a bit of context. The reason why we call it Health 15 is that our aim is that each engagement takes no longer than 15 minutes. We know that it's a construction site. They're there to build a school, a hospital, whatever they're building, and we really can't get in the way too much of that. So we guarantee that we're going to keep things within that 15-minute time frame. So the first step, alert and inform. We work with a key champion on site to get people excited about the fact that we're coming, promote the visit, promote the importance of having your blood pressure checked. We also do a bit of a needs assessment. So we find out what policies they have on sites already, and also what things they're interested in learning more about through toolbox talks potentially in the future, what they're generally doing to support health and well-being on that work site as well. Then we book people in for appointments. We don't want everybody turning up at the van at lunchtime and trying to come through. That's just not going to be a good use of anybody's time. So we book everybody in that wants to participate. It's voluntary, for a 10-minute appointment. So from downing tools to walking to our vans, getting through the vans and back on tools, that's that 15-minute window. In the third step, we come onto the site. We provide a free blood pressure check, sometimes several if the person has a high reading. We then talk with the person and provide individualized advice and support to that person. We talk about goal setting, and then if somebody's got a high reading, we actually give them a voucher to go and get another blood pressure check at a local pharmacy or somewhere that's convenient to them for free. For people that have really high readings, we offer them support for travel costs, the cost of going to the GP, and any lost income that they might get, so that we know that we've really broken down the barriers for those people to get support. And then people, as they're leaving, fill in a really quick exit survey for us, where we test some of those ideas around what they'd like to see happen on their site to support their health and well-being. We then, in the aftercare, so in the final step, we debrief with the key people on site. We summarise anonymously all the results and give them a bit of an overview of that compared to a national benchmark. We've been providing free blood pressure checks through the community for almost 5 years now. So we've had a lot of data that we can pull together and create a bit of a national benchmark around where blood pressure readings are sitting, and then compare that to the construction site. And then we also set a plan to implement those wellbeing initiatives that people want to see on the site as well. So in terms of results to date, we launched this initiative at the beginning of the year. We've had 7 construction companies sign up, and we've got a further 7 with proposals. We've done 20 sites. We've either completed them or we're about to do them in the next couple of weeks. To date, we've tested 480 blood pressures on construction sites, and of those people, 249 have been identified with a high blood pressure reading. 9 were in hypertensive urgency, so needed to go see the GP that day. In our exit surveys, we've found that 80% said they learned something new that they didn't know. It's amazing how much people don't know about salt and how hidden it is in packaged foods. That's a key learning that people often have. And 90% said that they were more motivated to take action to improve their lifestyle. This slide here just gives an overview of the infographic that we give back to key people on site to show those results. So you can see there on the left-hand side, we've got the results for a site, and then on the right, we've got the national benchmark. And the results are quite similar against the national benchmark until we get to that hypertensive crisis or the hypertensive urgency emergency category, where we've got 4% of people on that site needed urgent follow-up compared to the national benchmark, which is only 2%. And then down the bottom there, we've got a summary of the wellbeing initiatives that people wanted to see rolled out on their site. This slide here is just a bit of a testimonial from one of the sites that we were on. So in this particular site, we had 55 people that we tested. And we got great feedback from them. They had 7 people that took the step of consulting with their doctors, and some of those people were now on medication that they weren't on before the intervention. And then 5 people on that site also followed up with the free blood pressure vouchers as well. We've also had people get picked up for liver conditions that they had absolutely no idea they had due to having the high blood pressure reading, and then going and seeking that GP support. And then this slide here really just summarizes next steps. So when we designed Health 15, we specifically didn't brand it stroke related. Our goal is to broaden Health 15, and we're in the process of doing that now. We've got a proposal where we're working with the Cancer Society of New Zealand to bring in a number of engagements onto a site where we're talking about blood pressure, and then we're talking about SunSmart, and we're looking at how we strengthen their SunSmart policies, and we're looking for more partners so that we can provide a comprehensive service that promotes health and well-being, not just prevention of stroke, but prevents cancer, diabetes, heart disease, all of those sorts of things. The construction companies pay for this service, so our aim is that it's self-sustaining. Right now we have 2 vans that cover our North Island. So New Zealand has 2 main islands, North Island and South Island. We currently don't have a van in the South Island, although we can send our North Island vans down to the South Island. But we're looking to purchase another van and get that South Island coverage eventually. And with the income that we generate through this, we can then channel that income into free community outreach services, so going along to cultural festivals and those sorts of things. We're focused on construction at the moment, but we're looking to expand into other industries, so dairy processing, meatworks, forestry. And also, as I mentioned earlier, we're talking with a number of government departments to make Health 15 a prerequisite for procurement. So in New Zealand, our government has a priority around broader outcomes. So when they're purchasing service to build a school or build a hospital, they have conditions that mean that the contractor has to also invest in things like literacy and employing a certain percentage of some population groups and those sorts of things to try and improve health outcomes and also reduce inequity. And really a lot of this is around shifting. A lot of our funding at the moment currently goes into life after stroke services, and we want to be more of the ambulance at the top of the cliff, or the fence at the top of the cliff, rather than the ambulance at the bottom of the cliff. So it's a strategic move for us to move more in that direction as well. So if you want to learn more about Health 15, here's the website here, so health15.nz. And I think I'm now going to hand it back to you, Valerie.
Thank you, Julia. And first of all, I would like to thank all presenters for the wonderful presentations. It's really insightful and in a way encouraging to know how many diverse strategies are used in different countries for advocacy, for fighting stroke, for improving life of people after stroke. It's amazing, really. Very, very interesting, very useful presentations. And we've got quite a few questions. We may probably start with the questions we received, and then people who would like to ask questions, additional questions, please do so. We have plenty of time for the Q&A session. So the first question is to Michelle. Thank you for your great presentation. I completely agree that the third sector is under-recognized and in the design and delivery of care. But if the system becomes more reliant on the third sector needs to be resourced to do its job well and consistently. How can we ensure this? Michelle, that's a question to you.
So we're starting with a hard question. Yeah, thank you, Arlene, for the question. And, you know, this is one of those Pandora box questions, of course, because with funding, usually, if it's not if it's restricted funding or and not unrestricted, we know that it comes with requirements attached to it. So it's not as simple as, you know, finding additional funds, because we need to think about where those funds come from. Are they transfer payments from health organizations? Is it government funding attached to a particular commission service? And of course, that will then dictate what gets delivered, what gets measured, what gets reported, to whom, by whom, for whom. So, you know, it's really a very complicated question that you're asking, and I love it. I think probably the short answer, and I'd love to follow up and we can talk more about this, is actually thinking about streaming to the right place for the right program. So, you know, that rich associational life, and I noticed that both Lisa and Julia, in your talks, you identified places where individuals and communities can change behavior that is actually not within health system control. It's not within the ability of health system leaders or health systems to move. So, you know, that associational life comes from, it grows out of, it's a currency in and of itself. Whereas the work of third sector organizations requires staffing and support and resources. And so that's where things get a bit more challenging. You know, one of the cautions, of course, with third sector organizations is that at some point the organization becomes large enough that it starts to work to maintain itself. And that requires a different approach to fundraising and resource allocation. So your question is important, and it's multifaceted and nuanced. So it's not a simple matter of just ensuring that funds are available, because with that comes philosophy, expectations, and then it does actually influence the work that organizations do. So we could spend probably an hour talking about funding in the third sector and how that supports work.
Thank you, Michelle. There are a couple questions to Lisa. The first question about living guidelines. Can you explain in a little bit more details what living guidelines means, how it works?
Of course. So your traditional guidelines are, you spend lots of time collating all the evidence, condensing it, and then producing guidelines. And that can take many numbers of years. And as soon as those guidelines are published, then they become out of date because new research comes along. So the living guidelines model was developed to keep guidelines contemporary. So it's an ongoing process. So as new evidence comes out, that's reviewed by experts and incorporated into guidelines. So, for example, if a key paper comes out, it's looked at by the experts in that space, and then if it's deemed to be a significant scientific rigor and would change practice, then it's incorporated into guidelines. So what you see is, as evidence is produced, it's incorporated into guidelines, and then it's immediately can be implemented into practice. And when I showed the slide about the COVID guidelines, that's really the quickest turnaround time that we've had in the living guidelines space, because we had international experts across the world working on these guidelines and churning them out, because the research was really being developed so quickly. And that really came off the work that was done in the stroke space. So stroke really does lead in living guidelines, and in particular in Australia. So it's the way of I often talk about analogy. You've got a map in paper form, and now everybody uses Google Maps. That's kind of that instantaneous information of where the traffic jams are, the quickest route, and the living guidelines are kind of that equivalent.
Yeah, that's a fantastic new way. We actually advocated your approach to such guidelines in our recent Lancet commission. So hopefully people will pick up that approach. Often there are 10-year gaps between the release of new guidelines, which is not very good.
Not helpful, no. And then clinicians don't use them, and then what's the point?
Yeah. There are a couple more questions to you. One about planning, doing similar work for life after stroke.
Yes, so we definitely do a lot of advocacy around that. So one of the things we're working on at the moment is for survivors of stroke that have a stroke under the age of 65, there's this thing called the National Disability Insurance Scheme in Australia. And it's a complete minefield to navigate your way through, very hard to get funding out of. So we're doing some work on educating both health professionals and survivors of stroke on how to navigate through that, and advocating to the government for equity in funding. And there's other things, for example, in the sort of childhood stroke and young stroke area where it's under-recognized, so doing a lot of work to sort of bring that up to the fore. So yeah, lots going on. I just highlighted 3 things that kind of showed the advocacy journey.
Great, thank you. And another question to you: who is the key person that navigates stroke program in acute care hospital? Is it the stroke medical director, or do you have a stroke nurse coordinator that oversees quality and data reports?
Most of the time it's a stroke nurse coordinator that's responsible for entering all the data into the audit and our clinical stroke registry, and responsible for a lot of the quality improvement. But it goes hand in hand with the whole team, the clinical stroke lead as well.
Great, thank you. And the other question is for Julia. When people are discharged home, what information do they live with? Is this informed by a post-stroke checklist? Does this list look at medical and societal needs? How are people actually referred to your services?
So I have to put a little disclaimer
Few
in.
questions.
My area is in the prevention space, so I'm not fully immersed in the clinical or discharge space. I do know that in New Zealand we there's not national consistency. The way that hospitals manage things is different, and there's a real push at the moment to try and get national consistency, because we do have a lot of issues with people falling through the gaps between being discharged from home to getting back into their home and having needs that are not met. So all I can really say on that is that there's a big focus on trying to improve that. And then in terms of how people are actually referred to our life after stroke services, people can self-refer for that. Most of our referrals do come from hospitals. Some of them are good referrals, so we get a lot of good information about people. Some we just get a post-it note and a name on it, and that's a real issue for us. So we're trying to fix all of that up with the health system as well. We are also taking or trying to get some more referrals through primary care, but we don't get that many referrals through primary care at the moment. All that said, it's not, we have a lot of demand on our service, so it's not like we're looking for referrals either, but really just wanting to make sure that people that have experienced stroke are getting the support that they need, because like you're saying, Lisa, the services and support out there are a real minefield, and navigating all of that is when you've had a brain injury is huge.
Yeah, thank you, Julie. I can add to your answer, because I am also a part-time stroke physician at North Shore Hospital. So I'm involved in the management of stroke patients. And how we usually refer stroke patients to your service is through Stroke Foundation representative who attends our multidisciplinary stroke meetings, and they directly receive and communicate with the team the needs of the patient, and that take a note when the patient is discharged, and that's how they got the information about patient. But I must confess that it is quite unique service we have in New Zealand in terms of the field officers supporting post-discharge stroke patients at home or their place of residence. As far as I know, there is no other country in the world where such service is actually implemented, which is fantastic. And I know it helps a lot of people, because one of the frustrating things after hospital discharge, stroke patients and their families, they don't know where to go, where to get help, and what help they can get. Government support or other support, they have no idea. Most of them, even though they are told in the hospital what they can get and how, they keep forgetting it. And the other addition to that question about what people are getting after hospital discharge, kind of checklist, that's a big problem not only in New Zealand. Discharge summaries are quite not patient-centered, not patient-specific often in terms of secondary stroke prevention. A very good coverage of medications or procedures people need to go through, but very little about management of lifestyle factors, importance of adherence to medications. And it's not just New Zealand problem, it's international problem. And that's one of the reasons the rate of recurrent strokes in the world, in most countries, with some exemptions, of course, has not changed very much over the last 20 years. It's about 20%. In New Zealand, we have that rate for 40 years, 40 last years. In 1980, it was 23%. Now it is 19%. So it's not big progress. So that's the area, I think that's where we need to advance our care and support for the patients. Thank you, Julia. Sorry for the long answer. We have more questions. another question from Dr. Buffalo. I am a stroke neurologist in US. Question to presenters, basically to all of you. Thanks for your amazing presentation. How do you plan to translate your experience and expertise to low-resource countries? That question number one. And next question is to organizers. Why don't we have presenter from low-resource country to talk about the challenges and advocacy in those areas? So let's answer first question. How do you plan to translate your experience to low-resource countries?
I can go first if you like. So one of the things we do it is through the Australian Stroke Coalition, which is our coalition of interested parties in stroke in Australia, and we try and work and translate some of our resources into local languages for other countries. So we work with Port Moresby Hospital in Papua New Guinea, where we're trying to utilize some of the stroke protocols and implement them there. So things like that. And then obviously working with the World Stroke Organization through the SSOs and sharing resources. There's a lot of activity that goes on in that space too. Michelle can probably talk a bit more about that because she's been involved a lot longer.
Yeah, thanks, Lisa. So I will in a moment. I think the other thing I want to point out, though, is that the work that I do is actually not bound by geography. So the idea of civil society and the opportunities that arise from associational life and the relationship to formal institutions is actually a way to address lower resource considerations. I think we prioritize things that are funded, things that have funding through relationship to government, etc. But in fact, one of the best ways to address resource considerations is actually to embrace, promote, support associational life for the health promoting benefits that are there. So, as Julia noted, if you can actually support people in their communities to change their mindset around seeking help, accessing care, engaging in health promoting behavior. That's a low resource. It doesn't require a substantive resource from an external source. So I think there is an importance in thinking about promoting, supporting associational life. Now, that being said, we know that there is an opportunity for more formal structures to support equity, and the World Stroke Organization has a mandate and a value around promoting equitable access to supports and services. So as Lisa said, one of the things that she and I are co-chairs of the Stroke Support Organization Committee for WSO. And one of the things that we've been really advocating for within our SSO work is to promote sharing of support services, resources, materials, so that we do raise all boats, that it's not a material developed in one jurisdiction or not. And as you saw, we've talked to 92, Sarah Belson talked to 92 SSOs across 58 countries, and that represents a broad range of resource availability. So I think your question is important, and it calls to action the sharing of materials and resources so that we don't reinforce inequity. So thank you. I appreciate the opportunity to speak to that, and we'll take it on board for future work.
The only thing I would just reinforce that point around sharing, and we've had a real we're happy to share internationally with what we're doing, and I guess these sorts of events are great opportunities to be able to share what's happening around the globe and plant those seeds. But we've also recognised in at least our national space that we don't have to be the ones delivering this, that if there's someone that's better set up, that's going to resonate better with the communities that we're engaging with, we're happy to put them in the driver's seat and get behind them and support them to do that. So, we're looking with our community stroke advisor service It doesn't have to be our team that does it. Why not upskill health improvement practitioners and health navigators to be able to do that sort of role? Because the challenge that we've got in front of us, we can't do alone, and we'll never be able to do with the resource that we have. And similar with collaborating with other NGOs, we've got to break down those barriers of funding and collaboration and competition that often come with NGOs and competing for funding, and actually realize together we're better. So that kind of doesn't really answer the question, but reinforce the sharing point.
Thank you, Julia. And about the question about not involving stroke support organizations from low middle income countries. This webinar is just the beginning. We definitely will include in the future webinars on the same topic people from low middle income countries to share their experience. So that's a fair question, definitely. And particularly because of the almost 90% of the stroke burden resides in low middle income countries. That's a very important. We will probably next year devote the whole session to the burden of stroke in low middle income countries and how best way to address these issues in low middle income countries. So definitely we will come to that. It will be next year, a series of webinars. Dr. Narayan from India, good evening to all, and especially to my mentor, Professor Gary Ford from UK. Thank you for very informative talks, which helped me to get a glimpse of global cross-sectional view of your national and various important aspects of current stroke care. Just a basic question. What would be the capture rates of stroke data at national registries in your research nations, preferably at the community levels and also at hospital level? We have in our country still local databases mainly captured from hospitals and local community-based cross-sectional research databases, but these are still very sketchy. Even a recent national initiative in some service-based national hospital stroke registry of around 30 plus large hospitals is going at very low pace. That service is ambitious initiative like ADHAR, but it is still not taken off in a big way. Once it takes off, that will provide a more comprehensive information. Till then, it is still a far cry for a very big population like ours. I don't know who can answer that question.
I can try and make a start from Australian perspective. So we collect data in two ways. So we've got the National Stroke Audit, which is a retrospective audit of 40 consecutive cases, and we capture around 110 sites. And then there's also the Australian Stroke Clinical Registry, which is a prospective collection of data, and then we also have follow-up data as well. It is a definite challenge to get national coverage. In fact, it's one of the things that we are struggling with, and Bo Noving did an external review of the Australian Clinical Stroke Registry recently, and one of his strong recommendations was that we need to get national coverage, and it's one of our goals is to achieve that. But the way that healthcare is delivered in Australia, the state-based systems means that hospitals are funded by states, and it's all very disjointed. And then we also have the problem of different methods of collection of that data. So even in a country where we've had a registry for a long time, we've had the audit running for a long time, it's really very difficult. And without getting that national coverage, we can't do that proper benchmarking. It's not mandatory for hospitals to submit their data. We would like it to make it so, and that's one of our other ongoing advocacy efforts that we are undertaking.
All right. Thank you.
I can talk to New Zealand, and Valerie, you might want to add to it as well. So I guess the beauty of a country of only 5 million is that it's a little bit easier. So we do have national discharge data from hospitals. We also have a national health survey that happens every year that does ask people if they've ever been told by a doctor whether they've had a stroke. So there's a bit of capture there, but you know, some great work that you've been doing, Valerie, around the ARCOS study as well. I don't know if you want to add any more to that.
Yes, getting reliable data, and of course it depends on what kind of data you would like to get. But if we're talking about the burden of stroke, incidence, prevalence, risk factors, changes over time, or quality of care, it is really difficult to get. And what Lisa said, even in countries with established already for many years systems, it is quite difficult. In New Zealand, for example, we run population-based ideal stroke incidence studies, but we recently discovered, and there are evidence from other countries, that just single even really good quality epidemiological study in a single area of the country may not be 100% representative of the country at large, not representative at the national level. But we are now developing ways of combining routinely collected administrative data with the data obtained from ideal epidemiological studies. And that's probably the most cost-effective way of getting reliable national estimates of whatever metric you're looking for. We plan to publish it soon, but that's, I think, quite a new area, new strategy of getting national data, accurate national data. I don't know, Gary, if you would like to add anything to this question.
So in England and Wales and Northern Ireland, Scotland has its own, there's the Stroke Central National Audit, which has been running for, must be almost over 25 years. It was set up in the 90s. And that is pretty complete for hospital admitted stroke patients. And it still, the data are uploaded voluntarily without additional resource by stroke teams, but it's proved to be hugely useful for service improvement. It is looked at by the system of regulation of hospitals, so it would be a problem for a hospital if they now do not contribute to that. I think the data capture has improved over time, but I agree with the comment made, Valerie, that if you want to get a complete picture of like minor stroke and and sort of longer term outcomes, you do need to have some high quality epidemiological studies as well. And probably in that regard, we've got two in England, which are the Oxfam study and then the South London study. So I think that combination is needed. For one, for epidemiology, high quality population health planning, you do need some research epidemiological studies, in my view. But a database which is just in hospitals is incredibly valuable, of course, for improving the services and doesn't have to be complete beyond the hospital. What we are doing now is expanding the data collection in the community to help drive up improvement in community services, although we already have pretty extensive early supported discharge teams, and there are some voluntary organisations who provide support within those teams, although that's highly variable.
Thank you, Gary. We have 5 more minutes for the webinar. There are a couple more questions. let's try to answer as many as we can. What is your advice on how to start a community organization dedicated to stroke care prevention, to stroke care problem prevention, awareness, and so forth? Who should get defined? Health professionals, survivors, caregivers, by your experience?
All of those perspectives, I think, are important, and those perspectives together. I think, you know, if there's any takeaway from the discussion today, it's that no single sector, no single discipline can actually support people living with the impact of stroke alone. So it is in collaboration that we're going to make a difference. If you are interested in advice about starting a community organization, though, I strongly encourage you to go to the WSO website, reach out to Sarah Belson, who is our international advocacy and community outreach partner. She has resources. We have material to help you build a community organization, and you will be welcomed into the fold of our 92 partners, and we will help you as we can. So yes, there are resources to support you in that development.
All right. Additions to that answer? No? Yeah. Collaboration is the key word here. Who is taking care? Sorry? No, just a noise. Thank you, Michelle. Another question, who is taking care of stroke patients on specific aspects of stroke care in the state-sponsored old age homes routinely in Sweden, Australia, and New Zealand? I have some information about the UK since I was trained in UK for a while. So who is taking care of stroke patients on specific aspects of stroke care in state-sponsored old-aged homes? That's the question.
Well, I think it's a very good question, because from an Australian perspective, there's obviously, depending on the level of care that's needed, there's nurses and allied health professionals, but there is a real gap in aged care and a real workforce issue in aged care as well. So people probably aren't getting the care that's needed. And one of the things that the Stroke Foundation is trying to do is do an education program specifically for aged care to upskill some of the health assistants that work with the nurses and the allied health professionals, to really upskill them on the specific requirements for providing care for people in aged care that need extra support, because I think it is lacking. I don't know about New Zealand, but it's definitely a problem over here.
Thank you.
I'd say quite similar in New Zealand, definitely workforce issues, and also by that stage, you know, the primary care, that person's GP would be a key person involved in the care of that person in that home. But yeah, it's not an area that we've done a lot of work or advocacy in here in New Zealand, but there would be a need there.
Yeah. All right. Thank you. Thank you, Julia. There are two more questions, but I would suggest Gergana will email those questions to all speakers, and you just answer, and they will be placed on the chat room. I would like to ask Gary to summarize our webinar.
Thanks, Valerie. So first of all, I'd like to thank our three speakers, Julia, Lisa, Michelle. Really excellent overviews on a topic where I think we have a huge opportunity to really make progress, have more activity, and to better outcomes of patients, particularly supporting them post-discharge. But I think the point of working with civil organisations across the stroke pathway, particularly in prevention, is a really important one. You've seen some models here. I think the challenge from the questioner about why haven't we got more low resource country representatives here is a good one. We always try and do that on these webinars to get views from around the world, but we simply failed to identify speakers for that. But we will do so in the future, as Valerie said. So thanks to all those who've attended, and for those who've come late or registered and missed it, yeah, we do hope you enjoy catching up with this webinar. So thanks to everybody, and have a good day, night, or morning, wherever you are. Thanks.
Thank you.
Thanks. Bye.
Bye.